Good evening, and welcome to another edition of the OrthoCarolina live webinar series. My name is Steve Barchick, and tonight we're going to be talking about a condition called cervical radiculopathy, which is commonly thought of as a pinched nerve in the neck. This webinar is being live streamed on our social media platforms. If you think of any questions during the webinar, please type them into the chat, and I'll try to address them at the end of the presentation. Our goals for the night are, first, I'll give a brief introduction. I want to help you, the patient, understand what this condition is. We will discuss what we as physicians may do to obtain an accurate and appropriate diagnosis. We will go over what a possible treatment plan looks like for this condition. And lastly, I'll briefly touch on some of the options a surgeon can consider for treating this if non-operative measures don't work for you. I'm an orthopedic surgeon with subspecialty training in diagnosing and surgically treating conditions of the adult spine. That doesn't mean that every patient who sees me needs surgery. My job is to figure out your problem and develop a plan to treat it. If surgery is an option, during a clinic visit, I'm happy to discuss things I can do to help you. I became a doctor for a few reasons. First, I wanted to help others. To some extent, I think this is a vocational profession. I also like biology, science, and working with my hands. I'm originally from Ohio. I completed college at Harvard, where I was a varsity lightweight rower for 4 years. After college, my first job was as a commissioned officer in the United States Marine Corps. After exiting the military, I went to medical school at Duke University. But for all the Tar Heel fans out there, don't worry, my wife is a UNC alum. I completed residency in orthopedics at the University of Pennsylvania in Philadelphia. And after that, I completed subspecialty training in adult spine surgery at Emory University Hospital, including level 1 spine trauma call at Grady Hospital in Atlanta. I'm seeing patients at our Ballantyne office, our Indian Land office, and also at our spine center. I'd like to first start talking about anatomy. The spinal cord, the object in the middle of the diagram here, travels from the brainstem down between the vertebral bodies, or the bones in the neck, the thoracic spine, and the low back, or the lumbar spine. There are nerve roots, which are seen here in blue, that exit at every level of the cervical spine. These nerve roots branch off the spinal cord and exit through a space in the bones called a foramen. The nerves then go on to form a network of important other nerves, which we call the brachial plexus, which is in your chest and upper arm before it branches into the individual nerves farther down. These cervical nerve roots form peripheral nerves, which are responsible for telling your muscles what to do and also provide sensation to certain areas of your arm, forearm, and hand. So what is cervical radiculopathy? The term cervical means that this applies to the spine in the neck, or the cervical spine. And radiculopathy means this is a problem or a pathology affecting the nerve root. It is typically unilateral, which means it affects one side of the body. This condition can hurt. Some patients may note mild pain, but for others, they may note severe, debilitating pain that shoots from their neck to various parts of their shoulder, arm, or hand, depending on the location of the narrowing around the nerve root. Less common are sharp pains that shoot to the neck and head, but these may also be symptoms. In some instances, patients can have weakness in certain muscles as a result of the narrowing around the nerve root. Physicians who take care of patients with spine problems will often be looking for certain patterns of pain, tingling, numbness, and possibly weakness to assess where we think the problem may be. The clinical history and physical exam are very important. As a surgeon, I want to know how you started experiencing the problem, where you are feeling any pain and weakness, and how long these have been issues. Sometimes cervical radiculopathy can be a diagnostic challenge. It can appear in some instances like a compressive peripheral nerve problem, something like a carpal tunnel or a cubital tunnel. It may also be confused for other musculoskeletal problems like those we see in the shoulder, such as a rotator cuff tear or even osteoarthritis. There can also be other things on our differential diagnosis, things like postural or myofascial issues, among others. Cervical radiculopathy can be caused by a number of things. The first is soft tissue, such as a disc herniation, which is shown here on an MRI with the red arrow. The soft, spongy disc material can press through a small tear in the outer covering of the disc. This material, if it exits the disc, can cause severe pain because 1, it's physically compressing the nerve root, and 2, the foreign material causes an inflammatory. We're back. So I'm going to talk over treatment for this condition. So fortunately, this is a condition that we often think of as self-limiting, which means that most patients will get better with time. And we work on helping our patients reduce inflammation to control the pain. Physical therapy can be helpful. There are a lot of excellent physical therapists in town who can help treat this condition with a variety of modalities, stretching and strengthening. Some patients may also benefit from an assessment of their workplace ergonomics and occupational therapy for that reason. There are many medications that can help. Those that help control inflammation, things like steroids or non-steroidal anti-inflammatories. Muscle relaxers at times can be helpful, as well as medications like Tylenol, which is available over the counter, or some medications that are thought to have more effect, specifically helping nerve pain. It's best to see a physician or a provider to discuss these options to receive medical advice through a consultation. If the condition continues, advanced imaging can be helpful. An MRI and a CT scan show different things. The MRI is fantastic at showing soft tissue structures and neural elements. My personal style is to read the imaging, provide my own interpretation, and compare it to that provided by the radiologist. That's because I think having two minds independently reviewing the same imaging provides the patient a better assessment. CT scans can also be helpful, especially for looking at the bony anatomy, and at times they're used for preoperative planning if a surgery may be required. Some patients may benefit from an evaluation for an injection. This is done by some of our interventional spine physicians. At OrthoCarolina, we have a number of excellent interventional spine physicians or physiatrists. These doctors can offer patients expertise with injections that can deliver precision pain-relieving medication to the region of concern. If all else fails and surgery is required, I can speak to patients about options. We may also consider surgery if a patient is experiencing continued pain without relief, despite maximizing the non-operative measures. Additionally, if a patient is experiencing significant weakness, or if they're experiencing symptoms of narrowing around the spinal cord itself, something we call cervical myelopathy, we may be more inclined to discuss surgery as an option. The first surgery I'd like to discuss is called an ACDF, which stands for an anterior cervical discectomy and fusion. This involves approaching the spine from the front. We protect the soft tissue structures and remove the bone or soft tissue that is causing narrowing around the nerve root. The disc is removed and replaced with a device that promotes fusion, and typically a plate and screws are placed into the bone to increase the stiffness and help the bones heal together. Some patients may be a candidate for something called a disc replacement. Additionally, there is a procedure done through the back of the neck called a foraminotomy or a microforaminotomy, which opens up more space around the foramen or the region of bone where the nerve roots exit. Sometimes this can be done as a portion of a technique called a laminoplasty, which opens up more space for the spinal cord itself. I'd like to switch topics a little bit and talk about research. Being involved with research can mean a lot of things for a physician. Broadly, I think it falls into three buckets. The first is producing research. Producing high-quality research takes a lot of time and effort. At OrthoCarolina, we are an academic practice and have the ability to study our own patients. We can also participate in multi-center studies. Many of our physicians are involved with research through the OrthoCarolina Research Institute. Second, there are also a number of professional societies focused on addressing issues related to spinal pathology. These are all organizations important to us at the Spine Center because we have surgeons who are actively involved either in leadership roles, instructional roles, presenting research, or simply attending these conferences to improve our own ability to care for our patients. Third, research means openness to collaboration with other physicians and surgeons about patient issues. As a part of the Spine Center, I'm fortunate that in challenging diagnostic cases, I'm able to collaborate with other surgeons and physicians in our group to determine, first, the appropriate diagnosis, and second, an appropriate treatment plan. Sometimes that means talking with another spine surgeon or an interventional spine physician about a patient, or it may mean talking with one of the many other physician specialists we have at OrthoCarolina, whether that's a joint replacement surgeon, for example, or a hand and upper extremity surgeon about a specific issue that a patient may have. In a majority of cases, cervical radiculopathy will get better with time, rest, physical therapy, and non-narcotic anti-inflammatory medications. Injections from our physiatrists can help relieve pain, although weakness may be a reason to seek consultation for a surgeon. Surgical options such as an ACDF or an anterior cervical discectomy and fusion can help with this condition. Lastly, if you are experiencing any of the symptoms we've talked about tonight, it is best to seek consultation with a professional. The physicians here are members of your community and also have trained at some of the top institutions in the country, including many who trained right here at OrthoCarolina. We also have a fantastic team of physician assistants, nurse practitioners, and other medical professionals who work in our offices or behind the scenes to help take care of our patients as best as possible. With that, we will be open for questions, and you can learn more about OrthoCarolina and the Spine Center at our website or by giving us a call. So the first question is, if I do need surgery, can I get this surgery at an ambulatory center or do I have to go to the hospital for it? That's a good question. To some extent, it depends on the specific surgery you have, but there are many places, including at OrthoCarolina, where some of these surgeries can be done in an outpatient setting and patients will go home the same day. For example, with a cervical disc replacement or with an ACDF. So the next question is, 20 years after surgery, can the same nerve be impinged again? It can, if there's additional pathology that may be causing that to narrow. So if a patient has, for example, been treated with non-operative measures for, say, a disc herniation that resolve with time, medication therapy, potentially a steroid injection, that problem could potentially reoccur, in which case it doesn't necessarily mean that patient needs surgery, but they should seek consultation because surgery might help them, especially if the non-operative measures don't work. Can a nerve impingement in the neck cause headaches or earaches? That's a good question. So there are some patients may have a certain headache pattern that could be caused by a pinched nerve in the neck. It's best to see your doctor or someone about that condition. But there are instances where we see not as much earaches, but potentially headaches that can be caused by a pinched nerve in the neck, normally a little bit higher up in the cervical spine. Can this type of nerve impingement affect other areas of the body, particularly in the lower extremities? You can see this same problem occur in the lumbar spine. It's more common to see it there than it is in the thoracic spine, which is much more stable, especially due to the rib cage. There are patients that get this, and typically they can be treated again without surgery, with medication, with physical therapy, as in potentially with an injection to help with pain relief. Again, if you were experiencing something like this, it's best to be seen, especially if you have any weakness or if the issue has been recalcitrant to non-operative measures. The next question is, could the numbness and muscle loss in my hands be caused by a problem with my neck? It's definitely possible. that is something it would be worth seeing someone potentially about your spine. There are other conditions farther down in the upper extremity that can cause this. For example, two of the conditions that we touched on very briefly, which are peripheral nerve problems, one of them being carpal tunnel. In severe cases of carpal tunnel syndrome, you can experience not only numbness, but some muscle wasting. Additionally, the same problem can occur with cubital tunnel, which is caused by impingement of a nerve. Instead of it being in the wrist, it's happening farther up near the elbow. But for something like that, it's also a good idea to be evaluated potentially by an upper extremity specialist. Do nerve impingements heal on their own? At what point should you seek treatment? If you're experiencing any weakness, it's definitely worth being evaluated sooner as opposed to later. In some instances, if patients have narrowing around the spinal cord itself, they may have some issues with ambulation, meaning that their gait seems a little bit more unsteady. That's definitely a reason you want to seek an evaluation. Normally, with time, if the issue is due to something that's related to soft tissue, the problem can get better. And a lot of times we let pain kind of guide the patient. So if you are continuing to have pain, we'd recommend you be evaluated. Does nerve damage ever heal? To some extent, it depends on the degree of damage and how long it's been present. It's a little bit difficult to say, as each situation can be very different. But if you feel like it's something you're experiencing, it's better to be seen sooner as opposed to later. How would you know an impingement from arthritis? That's a great question. Sometimes the impingement can be due to arthritis in the neck, and there would be a number of tests that we could do in the office as a part of the physical exam when we assess your neck, potentially assess portions of your upper extremities to see if the problem is coming more from a nerve or if it's more coming from some of the bony anatomy and arthritis. In some situations, beyond an x-ray, it can be very helpful to have a CT scan to look at the bony anatomy of the neck. An MRI will give us a better look at the specific nerves and the spinal cord. There are also things that can be done when we look at the hands and the elbow to see if there's problems there that might be mimickers of things that are coming from the spine. I have numbness and pain in my left knee. I was told it's coming from my back. Could this actually be possible? It could be. It could be the same condition. So cervical radiculopathy, meaning it is a problem coming from the neck and affecting the nerve root, can happen in the lumbar spine, which we call lumbar radiculopathy. And this is a condition that we can see in patients kind of all ages, and it tends to be sort of in a sharp pain that comes from the back and shoots into the thigh or the leg in some capacity. So it depends on what your physician or a physician assistant or nurse practitioner thinks when they evaluate you, especially if it's worse with movement. It could be something that's more intrinsic to the knee, but that doesn't always mean it's the case. There can be times where patients may have bad hip arthritis and it may radiate to the knee. And at times it can be helpful to be evaluated by a hip and knee specialist for something like that. So good question. A little bit tough to tell without seeing you in person and getting to do an examination. Next question is, if a nerve block doesn't work, what is the next option? So if you were to go for a injection and that doesn't provide relief and you're still having continued pain, and we believe that the problem is coming as a result of your neck, the next conversation is likely to talk with a surgeon or a member of a surgeon's team to see if surgery is an option. Are there warning signs that nerve impingement is getting worse and needs urgent treatment? That's a good question. So if you are having pain that does not go away after working with physical therapy, medications, potentially an injection, that's a reason to believe that it's not improving. If you start having more significant weakness, if you notice you're dropping items, that's another reason that you should seek evaluation. If you started noticing you're having issues with how you're walking and you just don't quite feel steady, it doesn't mean that it's definitely coming from your neck, but there's a chance that it could be coming from somewhere in your spine, and that could warrant further investigation. Is spinal stenosis the same as nerve impingement? That's a great question. So when we talk about spinal stenosis, a lot of times we refer to it more in the lumbar spine, although it definitely occurs in the cervical spine. We typically talk about spinal stenosis as something that affects the canal itself. So in the cervical spine, that would be affecting more the spinal cord as opposed to the nerve roots as they exit. So they're very related, and in some instances can have a similar presentation, but they're slightly different in that the spinal stenosis we typically mention is something that's more central within the canal, whereas nerve impingement, we talk about it more as foraminal stenosis, meaning it's coming from the foramen. How can you tell the difference between a muscle strain in the neck and nerve impingement? Some of that is the type of pain you're having, what the quality of the pain is, the severity of the pain, whether the pain is exacerbated by certain movements in the neck. If you feel like you had an inciting injury, there are a lot of things that go into that. And it's something that's a little bit difficult to tell without physically examining the patient and getting the clinical history. But that's another very good question. My neck hurts and my forehead is tingling. Could this be related to a nerve impingement? That is a difficult thing to assess. There are other conditions that can cause tingling in the face that are related to some of the nerves in the face. Typically, for problems that are originating more from the spine itself, we think of them happening more in the back of the head, but that doesn't mean that's the case for every single patient. That one is a little bit more tricky. Will this issue show up in an MRI? In most cases, if the problem is occurring, if you're having pain that's radiating from your neck into, say, these digits in your hand, and it's coming from your neck, typically we would see some type of narrowing or foraminal stenosis, whether that's due to soft tissue or to some type of bony anatomy that's causing narrowing. That would likely show up on an MRI. We would be able to see that, and your radiologist would also likely make a comment of that when they produce their radiologic read. Can poor posture or working at a computer all day lead to nerve impingement in the neck? This can definitely lead to postural issues as well as myofascial pain, which can, in some instances, be mimickers of problems that are similar to cervical radiculopathy. So there's a little bit of overlap, and as physicians, we talk about the differential diagnosis, which is what's the list of things that could be the problem. And that is something that is similar to cervical radiculopathy, but may actually be slightly different, but would potentially benefit from an evaluation by one of our physicians or physician assistants or nurse practitioners. What is a typical recovery period from surgery? That's a good question. Some of that depends on the type of surgery you have. And it's a little bit, it's mostly based on that. For most patients, say if they have a single level issue, they would have a surgery done either in a hospital or potentially an ambulatory center. Most patients would be able to go home the same day. Some of that's dependent on the patient and their medical history, what the surgeon thinks of the surgery, if the surgeon has any specific requirements for the patient. And then typically we would have patients on some period of time where they're kind of out of work so they can recover and have a set list of medications to help them from a pain standpoint after surgery. What does recovery typically look like for someone with nerve impingement? Some of that depends on the severity of the impingement. Some of that depends on if you're having any weakness. Sometimes if you have weakness, that can be something that may not recover. Our hope is you may have recovery, but we normally would perform a surgery if someone is having weakness with the hope of preventing progression. So some of that's a little bit individualized. It depends on how bad the weakness is, how long it's been present. how functional the muscles are. There can be EMG or essentially electromyography studies that show problems in the nerve. And if those are pretty advanced, it could be challenging. But in some cases, patients will experience some recovery from it. I think most patients will note significant relief from the pain after surgery. So you kind of have the expected postoperative incisional pain, which is normal. But most patients, if we've addressed the correct issue, which we always aim to do, will have notable relief in whatever region of the body or the upper extremity where they were having that tingling and numbness and pain. How often do patients experience recurrence, and what can they do to minimize the chances? That's a good question. If it's a soft tissue problem, our hope is that that's the only time you experiencing it. But if there's been any change to the disc that has caused it to press out against a nerve root, there's reason to believe that that disc has some amount of damage to it. And while we hope that you don't have continued damage, there's a chance you could always have recurrence in that respect. If it's more due to bony anatomy, then it's something that potentially could bother a patient a little bit more consistently, I think. So a little bit depends on what your imaging looks like, both the x-rays, potentially a CT scan, and the MRI. Are there any lifestyle changes I may have to incorporate in my daily life to prevent further damage? That is one of the reasons why we often send patients to physical therapy to work on controlling their neck stabilization, and working on positions that are not going to put the neck into extreme ranges of motion and might put extensive pressure on certain joints or on certain discs. So that's a really good question. That's also a reason why some patients might benefit if they particularly experience problems related to how their workplace is set up, that an ergonomic consult could be potentially helpful, which you could talk to somebody about. Potentially even a primary doctor if that's a concern for you. Can scoliosis be a cause? Yes, in the sense that if you have not talking about scoliosis as a problem related to a curvature necessarily of the thoracolumbar spine, meaning the chest and abdomen and then the low back, but if you have some type of deformity or of your cervical spine, sometimes we see something called cervical kyphosis, which is where if you are looking at the neck from the side, it's sort of the neck's sort of creaching farther down. Some patients can experience neurologic issues as a result of that. So while we don't exactly call that scoliosis in the pure sense, it's a problem with the alignment of the cervical spine that can cause problems. Is imaging needed if I need an injection? That's a good question. And typically we would ask one of our interventional spine physicians to answer that question. Normally, if I think a patient needs an MRI, I'll try to order it. Typically, we'll try to get patients plugged into physical therapy pretty early for something like this with the hope that the non-operative measures will help them. But if we have particular question about the anatomy, and MRI can be helpful to help direct an injection into the right spot. Can nerve impingement after RTC surgery 2 months out during PT? So I'm guessing that RTC is rotator cuff surgery after doing 2 months of physical therapy. So you could have impingement in your neck that is due to a host of factors at any time point. There are certain nerves that come out of the spine that can, in some respects, be part of the differential diagnosis for a rotator cuff tear. But a rotator cuff tear is typically diagnosed both in the office and sometimes with an MRI. And so your surgeon has recommended surgery. That's to address that problem. You could be experiencing an unfortunate exacerbation of a separate problem that overlaps in the same region of the body potentially as where you had the rotator cuff problem. Pain mainly on the right side of my neck, but sometimes radiates into my right shoulder and back. Could this be nerve impingement? It could be. It could be. That's a good question, but that is a more common, what we say, clinical presentation, meaning that's something that a patient may experience when they end up either in my office or the office of one of the other surgeons here or one of the other providers that we have on staff at the Spine Center or at any of the OrthoCarolina offices. So thank you all for attending tonight's webinar. A reminder, a replay of this will be available on our social media platforms on Facebook, LinkedIn, and YouTube. And we'd like to thank you all for coming and hope you all have a good night.